So, welcome to Better Nurse Corp. My name is William. I go by Brown, and this is my partner, Ruzbe Rajai. And we are here to discuss a couple of things. Primarily pain. We're going to go over the pain scale. We're going to go over headaches. We're going to go over some cultural implications. But we're just going to have a regular conversation about being a nurse as well. So sit back, relax, and let's get this show on the road.
So,
all right. So,
you guys can call me Ruz. Because Ruz Berajay is too long.
Yes.
We'll get there.
And get there. Do you want to give the listeners a quick introduction? Like, like who we are, what our backgrounds are, how we met. Go ahead.
Sure, man. I call it serendipity. If you're not familiar with the word, it's your word of the day. So, a little quick background. So, I've been a nurse for just over 12 years. I did it as an accelerated program. Went to Penn State for my undergrad. Got a degree in biobehavioral health. Which was fascinating. On my way to med school. Took the MCATs, all that jazz. Very familiar stories for a lot of people, I think.
I didn't know that part.
Yeah. So, nice. And then to make myself, more familiar with, the processes, the mechanical stuff, I became an EMT, and then I actually was in the middle of paramedic school while I was doing the interviews and stuff like that. And I realized that's where I essentially learned what nursing was about. I actually I was doing intubations as a paramedic student in between interviews. And I was working with somebody who I thought was a anesthesiologist, and it turns out that the person was a CRNA. And I'm like, wait, you're not a doctor? He's like, no, man, I'm a nurse. I'm like, what? What does that mean? What do you do? Yeah. So he told me all about nursing, and he opened my eyes. So long story short, I jumped ship, did an accelerated 1-year nursing program. 12 months. It was the craziest thing I've ever done. I loved every minute of it. I actually dropped out of paramedic school to do that, which all my professors from the other one hated. Yeah. And then at the end of that, I became a nurse. I went straight into the ICU. I was in the ICU. After ICU, I came up, that was in South Jersey. Then I came up north. I bounced around between a couple of things that I did for NPs and critical care and open heart and different ICUs. And ultimately, I've ended up with my board certified in acute care gerontology. And I also do hold another master's as well in nursing as a CRNA as well. But I'm not a board certified nurse anesthetist, although I did graduate with honors. But that's a different story for a different day. I know a lot of people will comment on that. Why aren't you practicing? I promise you, it's a sad story, but it's not made for here.
Yeah. That's a pretty impressive background. I remember when I first met you told me that, I was like, what the hell? Like, bro, you're like everything.
No. And that's one of the things that you'll never hear me say, that I know anything.
Yeah. Very humble.
I don't know anything. Every day is a learning process. Every day is a experience, and it's just been a journey, man. And then I got lucky enough to meet you in my most recent employment, and we just hit it off, man. I was like, I found my brother from another mother, man. I was like, yeah. So
how we met at the hospital that we currently work at. And long story short, like really quick with me, like very similar background, not as much education, but I started off as an ED technician. So my first degree is biology. I wanted to be a physical therapist, and then I got talking to my sister and a couple other nurses, and I realized that, physical therapy is a great career, but there's a ceiling ultimately with physical therapy. But with nursing, I could bounce around into different areas, and which is why I said I'm gonna become a nurse. So I went back to school for nursing, and it was like you said, very challenging, but because I think I had the biology background, it wasn't as challenging as I noticed other students. But long story short is, I went to school, worked in the ED as a technician, and that's where my love for ED came from. And then finally, passed my boards, got a job in New York, and as a step down transplant nurse. And that's where I got the foundation of my nursing career. And then I eventually transitioned to the ED, and I fell in love with that for a while. But then I got bored, and I wanted to figure out, I got kind of in this limbo stage, trying to figure out where I wanted to go. And I found leadership, and I became assistant nurse manager, then transitioned to nurse manager. And then, now I'm here today with Ruse, trying to make better nurses, because, we work with new nurses, and we see a lot of great things, but we also see a lot of things that can be improved, that are lacking, that, we had when we were first starting out.
Pain, subjective.
Yeah. Pain, subjective. So why is pain subjective? Why is it important for nurses, new and experienced, to know or just remember that pain is subjective? Because sometimes we forget.
It's important because we experience the world through our own senses, right? I don't know what William is feeling. William doesn't know what Ruse is feeling, right? My interaction with my immediate surroundings are from my own sensories, from my own tolerances, from my own cultural tolerances, from my own physiological tolerances, right? It's one of those things where, something that might be some little pain for you might be a lot of pain for me, or something that might be a lot of pain for me, somebody else might be sitting there completely stoic, and we'll talk about that too. Right? So it's subjective. If I tell you it's burning, it's burning. If I tell you it's sharp, it's sharp. If I tell you it's dull, it's dull. If it's achy, it's achy. If I tell you it's the worst pain in my life, take your patient's word for it, right? Initially, at least, right? You should always take what they say and, hear it, assimilate it, and then assess and validate, right? And run tests. So,
Right.
most important.
And, to add on to that, like, you'll have your opportunity as a clinician to make your own assessment. And so that's when you might want to put your 2 cents in. But you cannot totally disregard the patient's 2 cents. And if it's a 10 to them, just like you said, it's a 10. Now, they might not be presenting to you as a 10, but remember, that's your frame of mind. That's your perception of them, but that's not how they're feeling. And so don't forget that part. That's super important. And remember, you're going to have your time to make your own assessment, and that's when you'll do so. You'll get your objective information, but you have to get the patient's subjective information.
Yeah, sorry. So when it comes to pain, we should also talk about some basic commonalities, right? Because if we just say pain is subjective, then we don't have any way to associate with that, right? Or relate to that, or be able to manage that. So we have different ways of differentiating pain. These things, for example, if you have pain that's in the acute phase, its tendency is less than 6 months. If it's chronic pain, that usually means that you've lived with that pain for more than 6 months now.
So if a patient comes in and says, "Oh, I've been in this pain for 9 months," the doctor is going, or the practitioner is going to say to themselves, "Okay, this is chronic pain. So if this is chronic pain, I'm going to order tests differently. I'm going to go into the patient's medical history a little deeper. Ask them, there's going to be a different type of investigating done versus if the patient comes in and they say, "All right, well, I've got this pain. I've had it for 2 weeks now. what happened? Different, maybe similar questions, but the questions or the investigation is going to be different.
You are a, licensed professional. You need to do your own assessment. Whether you're a doctor, a PA, a NP, or, an RN, your assessment matters. So approaching it with 6 months versus acutely, then you can, even further break it down, right? Where is the type of pain, right? We go on back to that beautiful, the who, what, when, where, and what, right? Or the OPQRST, or all that scales of being able to get that assessment in, right? Right. So we can categorize pain into 4 types of pain, right? We're talking about cutaneous, we're talking about visceral, we're talking about somatic, and we're talking about neuro. And then we'll even talk about the no pain.
So now you have the patient comes in, they'll tell you their subjective nature of the pain. Now you might ask them a couple of questions to get your objective information. But part of their subjective information is that pain scale, right? So
Correct.
Can we talk? Can we talk about the pain scale and why that's important?
Right. So the pain scale, depending on the situation and depending on the setting, and this is more geared for my new nurses graduating, just fresh grads. If you remember back in school, there are different type of pain scales for different type of scenarios, right? You have pain scales that are numerical. That's somebody who is awake alert oriented, somebody who is able to speak to you, right? And being able to follow basic commands, right? So the quote unquote normal patient that you can interact with. Then you have different types of pain scales, right? What if the patient is handicapped? You have a pain scale for that. What if you have a patient who is intubated, right, or sedated, or purposely keeping them unconscious? There's a pain scale for that. So pain scales are important to know in the setting that you're in, because that's what you're going to use, right? If you're in med-surg, you're going to use, most likely the numerical, right, for the most part, or the FACES, right, if somebody's mentally, challenged or something to that effect. So depending on the type of location that you're working or the setting that you're working, then you're going to use that appropriate scale. So this way we have an objective way to discuss things, right? So in general, we're talking about mild, moderate, and severe pain, right? And no matter how you scale it, right, different methods, but at the very end, you're kind of approximating it in those 3 general categories, however you come to it, right? Something that's, and the equivalence, I'm going to use it as an arbitrary example, but the equivalence is that from like 0 to 2, 0 to 3, that's mild, right? And then 3 to 5, 3 to 6, that's moderate, right? And then everything after that is usually severe. And then based off of that, then you look at your modalities of treatment and you decide how you want to approach it, right? And most people do this innately. Most people do this before they become medical professionals at home, if you think about it, right? You go roll your ankle playing basketball, or you roll your ankle playing football, or you get a sprain, or tennis elbow, whatever, right? What do?
I mean, those are things that you're not going to go to the hospital for. You can treat
right.
that at home. You can put some ice on it. You can wrap it up. You
Right.
can elevate, rice.
Right.
Yeah.
Right. So those are your non-pharmaceutical approaches, right? And believe it or not, in the hospital, that's how we start. So for my non-clinicians who are watching this, and you just happen to stumble on this wonderful podcast, don't expect to be in a hospital and just automatically get pills right away, right? But unfortunately, and this is the controversial stuff, we live in a society of pill popping, right? Big Pharma, I love you guys. You do a lot of great work, but you also do your own, thing. And people automatically expect to either be completely pain-free or immediately get a pill, which is sad, right? Yeah. Elevation, heat packs, cold packs, movement, whatever, when appropriate, of course, right? Because you should never deny anybody of pain, but at the pain medication. But at the same time, you also want to make sure that your assessment and your intervention is appropriate. So we always start off with that, or we use it as an adjunct, right?
And you should, in my opinion. I mean, given the fact that, like, we work with medications all the time as nurses, and we have a good understanding of how the human body works, and that all medications have side effects, right?
Right.
So because of that, you want to try to not take those things unless you absolutely have to. I mean, and this is my own subjective opinion. Like, so what I'm at least communicating with patients, or even dealing with my family, and when their first instinct or default is to take a pill, and I'm like, no, let's treat the underlying cause. Why are you in pain first? Let's figure that part out. And then, let's solve that problem rather than masking something for 6 and 7 months, and when you could have just eliminated the issue from the beginning or prevented it from happening.
Correct.
So that's super important that you mentioned.
That's a great
that.
point.
You want to start off with those things first, and then gravitate to a pill.
Yeah. That's a great point. I mean, after a point of injury, you shouldn't mask it with other thing. You should get it assessed if it's severe enough. Even if it's not, it's probably a good idea to have it looked at, unless it's very superficial, obviously. And then being pain free. Can we talk about that real quick before we actually delve into pain?
And being realistic with your pain freeness. I know, but go ahead.
And that's exactly where I'm going. You see this?
Yeah.
That's exactly where I'm going.
Yeah.
For my non-clinicians, I want you to understand something. When you come into the hospital, it is not meant for you to be completely made pain-free. Pain-free means two things. Pain-free either means you're dead and your nerve endings are dead, right? Either one, right? The nerve ending is no longer firing and it's completely dead. And even that, you still might be feeling pain. Not the dead part, but the nerve ending part. Or there was no insult to injury, and therefore you're not in active pain, right? Everything else in between, it's a tolerance game. We give you medication for you to be able to tolerate your pain, that you may ideally do your daily activities, right? It is not made for you to become high. It is not made for you to, get a buzz off of it. It is not made for you to, be completely pain-free. And some people come into the hospital after an injury and they think that they should be 100% pain-free before they're discharged. And that's just not the case.
Not the case at all.
No.
And you have to be realistic. And I think that clinicians need to also be realistic with their patients. And
setting expectations is key. It's worth repeating. Setting expectations is key with everything, right? Yeah. You got kids, you want your parents, you set expectations, right? Yeah. We set expectations with our patients just the same, right? You're coming in, it's a new environment, it's a new thing. We need to inform you, we need to educate you so there are no surprises, right? Because TV lies. Yeah. Movies lie. Yeah. We don't chalk a flat line. Spoiler alert.
Yeah. I mean, they advertise these things like you could just take a pill and then your life is going to be better.
Yeah. Have you seen these pill commercials for like eczema? So these are essentially like borderline cancer drugs, right? They're a lot of these things are autoimmune stuff. So these are anti-immune. It's lovely to hear the way they just portray it. And if you know anybody who actually takes these, and I do, not just my patients, but like family, it makes you feel like you're on a, immunosuppressant drug. It's disgusting, right? Yeah. But the PR makes you look like, you're jogging and doing everything else is 100% normal. And some people, it's like that, but there are side effects a mile long for a reason. Yeah. I
mean, the human body is absolutely phenomenal. It's amazing. But I'm willing to bet, like if you're in chronic pain, you've been in it. It took a while for that chronic pain to develop, and it's going to take some time for it to heal. So that the body's amazing, but you also got to give the body time.
Yeah.
And so you can't just take a magic pill and then expect to be 100% the next day. You have to actually let your body and your
Heal.
cells regenerate. And you have to heal.
Yeah.
Rest. Yes. All of that. But we mentioned the four categories: cutaneous, neuropathic, visceral, and somatic. And I want to dive a little deeper into that. So let's go into the first one, somatic. What is somatic pain versus visceral pain?
So actually, if you want to start it from the beginning, we'll start from the outside in then, if you don't mind. Because cutaneous is first, right? That's your skin.
Yeah.
Right? So an example of that, it might be a small, water burn or a heat burn or sunburn or something like a herpes virus, like shingles, right? I'm sorry, no, not shingles. Common mistake, sorry.
That's neuropathic,
Not that's
right?
neuro, but we'll get there.
Yeah.
But herpes or chickenpox, stuff like that.
Yeah.
So that's your cutaneous. It's superficial. It's, tolerable on some level. And yeah.
So we have cutaneous.
Yep.
So what's next? I'm assuming if you're going from outside in, we got to do visceral then.
We
next,
got
right?
visceral, right? After that, you got your organs, your internal organs. So that's like your peptic ulcer. That's like your, gallbladder pain, right? So somebody who comes in with, shoulder pain or, their gallbladder issue, the back of their shoulder blade is painful. That's, spoiler alert, that's most likely their gallbladder. At least, the typical presentation. There are atypical presentations in your assessment, but I think that's another lecture in itself when we do assessment skills. But, your typical, your stereotypical assessment for visceral would be something like that.
As an ED nurse, I would have patients come in and they would say, I feel like this pain is somewhere inside. And, so they won't say visceral, but they'll say somewhere inside. And I think that's important for you to, like, if you hear that it's inside, just kind of don't automatically assume it is visceral, but, make it a consideration that it's visceral pain.
Mm-hmm. Yeah, it's diffuse pain, right? It's not like a specific nerve ending. They're not going to be able to just immediately just point in one location and say it hurts here, right?
Right.
Neuropathic,
right? Yeah.
Yeah. So somatic, you got your muscle, you got your nerves, right? Your soft tissue injury. So that would be considered somatic pain. Underneath that, you get neuro pain. Right, that's more like shingles, right? Because the virus lives on nerve endings, like sciatic pain, right? So it's a patient who comes in and they have pain radiating down one of their leg. It's possible, a sciatic pain.
And I've had shingles before, and I will tell you that it is excruciating. It is excruciating pain. Woo. So if you ever see a patient that has shingles, feel bad for them. Trust me, because it's having experience with myself. It's not fun.
So speaking of that level of pain, I want to talk about something real quick with that. People who are in pain might not be the nicest person in the world, right? Can we touch upon that real quick?
Yeah.
Side conversation.
Yeah.
Please.
This is the real talk right here.
Yeah. Don't not give your patients medications. And this is not for my conspiracy theorists out there that the hospitals are not, giving pain meds appropriately and stuff like that. But if you look at the literature and if you look at cultural studies, there has been shown evidence of biases and I'm not going to go into, more than that, but there are certain biases that people have, right? Regardless of race, sex, religion, or whatever, or all of the above. But for whatever reason, that personal, they might not see it. And it goes back to that pain being subjective, regardless of history, right? So, and this is what I was kind of referring to, that some people they might come across because they're in acute pain, or they might be in chronic pain, but their pain level is so high that they're not thinking normally anymore, right? Or they've lived with it for so long that it's just made them a miserable human being. And you have to be understanding of that, right? It's gotten so bad that they're in the hospital seeking pain, right?
I am an advocate for everyone being respectful of each other no matter what.
Yeah.
But, when you're in excruciating amount of pain and you just want to get out of it, and so I think that as clinicians, we have to be remembering of that sympathy that we need to be that for that
Right.
patient. And so if they are coming at you and they might not be the nicest people in the world, just don't take it personal. It's not you. I promise you, it's the pain.
Yeah. And that's the thing. We're there for the patient. We're not there for personalities. We're not there for anything else. We're there for the patient. So whether in the private setting or inside the hospital, are headaches, like you said. And understanding headaches, I think, is important because, I think we can also teach. I think it's simple enough that we can teach the population about this without getting too technical, or at least giving them some verbiage that they can use with their clinicians or when they talk to their healthcare providers. And so the first one is what I think what everybody's aware of is like a tension headache, right? I think there are enough commercials on TV about different medications that people take for tension headaches, right? It's the most common. It's 90% of the signs and symptoms of it are they feel like it's a vice, like pressure pushing down on their head, right? Tightness. It's a general back of the head type of pain, right? It might radiate down your neck. And believe it or not, for this type of headache, a 20-minute, 30-minute nap, no more than that, because then you get into that circadian rhythm stuff. But 20, 30 minutes of it, of a closed, dark place, whether you get a nap, whether you meditate, whether you just go and close your eyes and let the tension, wear off, that pain usually will actually subside. So that's your tension headache. So cluster headaches, these are more common in middle-aged men. And you're going to hear us talk about certain signs and symptoms in a general, stereotyped, or like evidenced by like the norms, right? So just putting it out there. Middle-aged men, after alcohol use, severe, it's usually unilateral. So that means it's half of their head, whether the left or the right. It usually involves around one eye. You can wake up in the middle of the night with it, but not to be confused with a stroke or TIA or anything to that effect. But usually, you can wake up from it. It can last from less than 2 hours to, a couple of days. You might have nasal congestion. You might have eye congestion, like around the eyes and the nose. Some people might think it's sinusitis. It's very close to that, right? A lot of these people, if you also give them like 100% oxygen, a little bit, 2 liter oxygen, or some tryptophan, it usually makes it go away, right? Cluster medications, you can also take over-the-counter medication, pain meds. Your traditional acetaminophen would do for it. Some people like taking ibuprofen, but that's more for if the tension headache persists. It's an anti-inflammatory, so you want to treat the causality of it, right? Cluster headache, maybe acetaminophen, maybe the Imitrex, if it's very severe. For the tension headache, the rest, the heat, or some acetaminophen or ibuprofen for that one.
Right. So just to add, whenever you're talking to your patients and they say they have a headache, you know, take it seriously, you know, because it could be a medical emergency. So you
Right.
want to ask them, how bad is the pain?
Right.
Can you rate it from 1 to 10, 0 to 10 rather?
Yeah.
Where is it?
0 to 10.
Do you have any dizziness? Do you have any nausea? Is the room spinning? Because vertical, it could be vertical. It could be a number of different things, but you definitely want to take it seriously because it could be a medical emergency.
Right. Such as
one of the questions that, it could be a stroke.
a stroke, right?
It could be a TIA.
It could be a TIA.
Yeah.
Exactly
Yeah.
right. There's two usual categories of migraines. Your classic and your common, right? The biggest difference between the two is that the classic and the common don't have an aura, right? Do you remember what an aura is? Just so.
So it's nebulous. I mean, I know what an aura is, but
we went big.
it could be
it's nebulous.
it could be nebulous in some respects, but I mean, to describe an aura, you feel like there's a light around you or around other people, and so if your patient's trying to describe it, it will sound nebulous for the most part, because how do you really describe that? It's kind of hard. But just understand that if they say if they see a light or weird light around you, they're probably saying it's an aura.
Yeah. So, and that wasn't meant to be putting you on the spot. It was just to
it's
point out that everybody
It
who
is
answers about the aura thing is slightly different. I mean, there's an actual definition in the dictionary if you want to go look it up, but the generality in practice that I've come across when patients talk about the aura, they talk about different things. And then aura is also mentioned in a very similar thing called seizures, right? So both, but we're not going to talk about seizures here, but it's very similar. So is it a seizure or is it a migraine, right? And or what type of migraine then? So to circle back, aura is present on classic and common, does not have it, right? So aura in classic, but not in common.
I found that women complain of headaches a lot more, migraines more specifically.
Yeah, migraines. So
a lot more than men.
Yeah, so the studies have shown that females are more prone to headaches. So if you think about, and I'm not associating this with being female in any way, but I just want to go back.
Yeah.
A migraine is a dilation of, the branches of the carotid usually, right? It can last from 2 hours to 3 days kind of thing. It is one of those painful things that it's debilitating for people, right? I actually get personally common headaches, common migraines. And it can be debilitating. It's one of those things where you end up in a ball, under your covers, in the dark, no noise, no nothing, right? So men get it as well, right? And the triggers are different things. But luckily it's not the classic, and I don't have auras or anything like that, right? Oh, by the way, auras. People sometimes call it deja vus or like weird, funny feelings, and not just visual disturbances as well. I just want to put it out there so people become familiar with that. The studies have shown that females are more prone to migraines. And if you, in their H&P, when you're assessing them, if you talk to them, they usually will say, my sister has it, I have a family history of it, my mother had it, right? It started when I was a kid. When I was younger, I was prone to headaches. In my early adulthood, they have triggers, right? I briefly talked about triggers. There's stressors, right? It could be physical, it could be chemical, it could be from medications, it could be from foods, right? Certain foods have nitrates, right? So deli meats, right? Every time I had a salami sandwich or a cold cut sandwich that has a lot of nitrates in it, I end up with a migraine, right? So they might come in, they'll say, so when you're talking to them, when was the last time you ate? When was the last time you drank something? When was the last time you had some alcohol? When was the last time, you smoked? Like, these are all different triggers that might not be a trigger before, but it is now, right? Our physiology adapts and changes over time. So what wasn't before might be today.
You have to know who you are. Like, you have to know your body. And the better you know your body, you'll know what it needs. Like, for instance, I know if I have a headache, I'm most likely dehydrated.
Right.
Gonna need to drink drink some water to hydrate myself. Like, so a part of this whole journey of life is to learn your body and to learn how it functions and to be aware of certain things. So, for some people, they might not be dehydrated. They could have, had a drink, like you said, and sometimes drinking makes them have headaches. So everybody's body is different, subjective. This is why also, to bring it back to the subjective nature of pain, you just have to go by what they're saying, because you can't argue with
Right.
like, it's them. It's their body. Like, you're not living in their body. You're living in your body.
Worst headache in my life. I come to you as a patient, worst headache in my life. What's the first thing that you should be anticipating?
So obviously labs, but definitely a CT.
Yeah. CT of what? The head, right?
A CT of the head,
Right.
yeah. CT of the head, yeah.
So we're essentially, we want to create so let's say they didn't have a history of a fall. So some people might be thinking, well, why would you get a CAT scan, right? So for my new nurses, just as a reminder, it's because you want to set a trend. You want to have a baseline. Having that CAT scan show a negative CAT scan, and it's negative for a bleed, by the way, right? So there's two types of the CAT scans that we're looking at. We're looking at for a active bleed, so a hemorrhagic stroke, right? And the only time we would see any type of ischemic stroke, it's if it's old, right? If the damage has already been done, kind of thing. But right off the bat, we want to make sure that we want to rule out that it's not a hemorrhagic stroke. So we know, because that's a medical emergency, right? That's a medical emergency. And if they have neuro exhibit, right, and they're flaccid on one side, or they can't neuro, and that to that level, we also want to assess that as well. So a complete neuro exam is warranted for somebody who shows up with a pain, especially if the words "worst headache of my life" ever happened.
Yeah.
Right?
Yeah.
Right. And you do the CAT scan before they might want to rule out something else that's adjacent to this as well, which is meningitis. Right? We want to make sure, because the CAT scan is even more important to do, to make sure before you do an LP, right, a lumbar puncture for a patient, you want to make sure that they're not actively bleeding, right? So a little spoiler alert, we're a closed loop system. If you're bleeding in the head and I pop the keg at the bottom, right, it's like shotgunning a beer. Everything just going to come straight out, right? So if you have a massive bleed in the head and you go do a spinal tap on somebody, that you can potentially cause a shift, and they might actually herniate. So you have to be careful.
Wow.
So it's two things that we're trying to make sure that we're looking at. So when your practitioner's ordering a CAT scan, it's important. It's important for a reason.
So, the patients come in with pain, and we have already mentioned that it's a good idea to give them non-pharmacological treatment. But in the event that those things don't work, which is common, and some people
it can be treated, non-pharmacologically, it's most likely treated at home, right? I think every mother, father, brother, sister, relative, family member, whatever, all the pronouns. It's something that they can take care of at home, right? If they're in the hospital, at least it should be, right? Yes, you do have patients who come in just because it's the most.
As an ED nurse, I will.
I will attest that the ED is used as a doctor's office.
Lord have mercy.
Or a practitioner's office, whatever. Medical offices are not the equivalent of emergency rooms. Please see your primary whatever first, then go to the emergency room. That's Brown's request for the public. That's his PSA.
This is for every ED nurse in the world. Rise up. Say
the struggle is real, bro. Yeah,
Lord.
yeah. The stuff that you see in the ED, man, I give you a lot of credit. My hat goes off. Let me first and foremost, I should have said this at the very beginning at your intro. My hat goes off to all ED nurses.
Yeah.
Full stop.
Absolutely.
End of sentence. Hat seriously goes off. As an ICU brat, I will never ever pretend that, or a med surg tele step down. When it comes to having 5, 6, 10, 15, 18 patients to one person, depending on wherever you work or the circumstance you find yourself in, because this is healthcare. The doors don't close. We still are expected to take care of patients, whether half the floor has called out sick or not. Right? We're there for the patient. So generally speaking, there's like 3 levels of treatment, right? You want to start off obviously with your non-pharmacological, and then you start off with your basic over-the-counter stuff, right? Your aspirin, your acetaminophen, your NSAIDs, your ibuprofen, plus that non-pharmacological, sort of heat pack, repositioning, elevation, icing, depending on what the need is, right? So that's level 1. So it's your non-pharmacy based one plus some type of level 1 pharmacy pain med. Then you have your level 2, which is maybe your one of those medications plus an additional, right? Such as like an opioid, like a codeine, right? So in the hospital, it's good for you to know that patients come in and you see something called Tylenol 3, right? That's codeine. That's Tylenol with codeine. So that's your level 2. So it's a non-pharmaceutical one plus something. So acetaminophen plus codeine, that's level 2. Level 3 is your more powerful. So it's still your first choice, right? Your acetaminophen, ibuprofen, whatever it may be, plus a much more powerful opioid, such as like a hydromorphone or Dilaudid. Right. Now, when we're talking about that level of pain, we're talking about very extreme pain, right? We're talking about post-op pain. We're talking about cancer patients. We're talking about, stuff like that. For cancer patients, other medications like biphosphonates or for like osteoporosis, right? These things will help them. But those are essentially your 3 levels of pain treatments, modalities.
Right. And so, it's important to remember those, obviously, as a nurse, because you're going to be giving these pain medications.
Right.
You're going to be distributing them, and you're going to need to know, what they are. Not really, but you should know how they work, just in case the patient asks. But you're going to be dispersing them, and you're going to have to know the side effects. You're going to have to basically explain, the basics to the patients and the family members.
Yeah. I'm not going to get into the soapbox of side effects, but side effects are huge to know. Tylenol has a hepatotoxic limit, right? It's usually about 4 grams, I believe, within a time period. So knowing the patient's history, right, is important. Are they compromised in the liver? If you're taking ibuprofen at home, do you have kidney issues, right? Knowing that, different organ systems, depending on how they eliminate or they metabolize the medication is important, because knowing that, then you understand whether it's appropriate to give to the patient or not appropriate to give the patient. Because keep in mind, and this is what I hope people get out of this series of podcasts and our conversations, is that you should be thinking about when you're approaching any type of medical problem from the global to the, critical, right? From the general, from the umbrella term to, the levels, peeling the levels of onions down to be able to get to the core of the reason. And if you can train your brain to think about whatever, right? Pain, right? Pain is subjective. Pain is an umbrella term. Then you get into your assessment. Then you can think about the medication that you're giving, the reason why you're giving it, is it appropriate or not, and the side effects that are, with those quote unquote over-the-counter medications, the benign medications that people have come to believe that, oh, it's just ibuprofen. I'm just going to pop a couple of Advils and I'm okay with that, right? Most people don't know, like for headaches, depending on the headache, NSAIDs actually potentially might increase, your ICP, right? It might not be appropriate for that headache. Counterproductive, right? Yeah, so yeah. It's whether it's for yourself or when you're taking care of patients, understand why you're taking the medication and the side effect of it, because you want to make sure it's appropriate.
So we covered a lot. We covered the subjective nature of pain. We went over the pain scale, mild, moderate, and severe. The differences between acute and chronic pain. We also touched on the 4 categories of pain, which is cutaneous versus neuropathic versus visceral versus somatic. And then we went over headaches. And then we briefly touched on the cultural implications of pain. And then lastly, we finished up with pharmacological treatments, level 1, level 2, and level 3. But then we're going to have a corresponding cheat sheet, for lack of better terms, about everything. So for you to study and for you to review without listening to the entirety of this episode. We're going to touch on those key points in there. Anything else you want to add before we?
No, I hope everybody enjoys this. I think this is a product of love, and we truly care about our new nurses and our seasoned nurses, and I hope that this community grows and continues to grow, and we learn from each other and we teach each other and support each other, because I think it's important. I think we're going to talk about a lot of vital things. And I think we can use these dialogues to be educational, right? Things that we might have not thought about for a long time. And we continue that learning process, because I don't want our profession to be seen in a negative light in any way, right? It's one of those things where I want to elevate our profession, and I think there's a lot of smart people out there. And I look forward to meeting all of you. And I love the fact that I'm working with you, bro. And
same here, man.
Thank you, man.
And I before we end, I hope to use this show to push, like you said, push nursing forward, but push it forward. Like my ultimate goal, federal changes, federal like lobbying for anything like nursing related federally.
So we're getting into politics. Practices. Is that what you're trying to say?
I mean, I that's my ultimate goal for this, because I think that nurses, we, like you said, we're so bright, we're so adaptive. We need more of us making these decisions when it comes to major healthcare decisions.
We should have a seat at the table.
We need it. We need it because we make up most of the hospital, right? We are more powerful than we
give ourselves
have credit for at this moment right now. And
and that's not being political, or that's not being union or anti-union or anything like that.
No.
But the reality is, right? The reality is that nursing is one of those fields that's truly like a tree with a million branches. Right? Yeah. We can be in so many different things, direct or indirectly, when it comes to healthcare. And I think if more of nursing mentality were to be interjected into the politics of healthcare, I think we would gain a little bit more humanity back into it. Yeah.
Right. And still make money, because it's a business.
Oodles of money. Yeah.
But we'll get our seat one day. If we don't have it already, well, we're gonna get it, and we're gonna get more seats. But anyway, yes, this has been another great. Well, this has been the first Better Nurse Corp podcast. Looking forward to much more, and tune in next time. And let's get ready to learn, make better nurses.
Love it.